Thank you, Dr. Kumar. And with that, we will move on to the fourth section of today. And in order to take that forward, may I please request our respected chairpersons and panelists, Dr. S.C. Mondol, Dr. Debashish Ghosh, Dr. Amit Roy, Dr. Joy Shannal, Dr. Shomo Patro, and Dr. Indrani Sham to join the session. We will begin with Dr. Priyam Kumar Mukherjee, and I'm requesting Dr. Mukherjee to present his talk.
Yeah.
Welcome, Priyam.
Yeah. Yeah. Good afternoon, respected panelist and chairperson. So, can I actually share my slides? Yeah. Yeah. Is it okay? Oh, fine. So, I would like to thank CSI West Bengal branch for giving me the opportunity, and also I would like the topic very much because it has a very depth insight and what should be the management of hyperkalemia in case of heart failure patient. And I was actually listening to the previous speaker. He has also commented several aspects of hyperkalemia because most of the drugs we use in this heart failure patient they cause hyperkalemia, and we have to either reduce the dose or stop. So, what are the myth? What should be the logical rationale of your adjusting the dose or continue or discontinue? So, I will next 15 minutes I will highlight over those. So, this is a slide. Actually, we go through this slide in our internship and medicine MD during our medicine course, and this is the distal cortical collecting duct and the principal cell and the intercalateral cell, which are actually involved in the potassium homeostasis. So, these are the sodium potassium ATPase channel in the basolateral side, and your sodium channels in your luminal surface, and with the help of aldosterone and there is some stimulation of the genetic issues, and ultimately sodium is retained and the potassium is excreted. So, this is the important uh, site where the potassium is regulated in our body according to the level of sodium itself. Potassium is itself is a stimulator or depressor of your adrenal cortex, like that. So, what is the real scenario? So, among patients hospitalized for the heart failure, the prevalence of hyperkalemia has often observed is 1 to 10%. So, it is quite a good number. And with growing number of CKD and heart failure patients taking the RAS inhibitor and the mineralocorticoid receptor antagonist, that is the MRA, hyperkalemia has become more common concern. Many patients in need for these therapies are unable to tolerate them, or if these medicines are prescribed, they are prescribed as a less than the optimum dose, and RAS inhibitor discontinuation for hyperkalemia represent an undesirable clinical compromise. So, what are the causes of hyperkalemia? Yes, the treatment of this ARNI inhibitor or ARB, this MRA, phenylephrine and epinol, and particularly the CKD subgroup. Thus, previous speaker has highlighted many aspects with the CKD patients. Diabetes are more common, particularly those patients with diabetic and CKD. They are more prone to this hyperkalemia, and concomitant your medicine use like NSAIDs, like that. Now, one fact is that this is very interesting. So, the use of AC inhibitor is attributed to the development of hyperkalemia in 10% to 38% of the hospitalized patient, whereas hyperkalemia developed in up to 10% of the outpatient population within 1 year of prescribing RAS inhibitors. And in patient with the CKD, the prevalence of hyperkalemia can be up to 20% and is associated with the risk of mortality and major adverse cardiovascular events and discontinuation of the RAS inhibitors. So, what is the larger evidence in the paradigm heart failure trial? Despite renal function, potassium-based eligibility criteria, and a running period, approximately 15% of the patient in both these groups, this sacubitril valsartan and the enalapril, they develop hyperkalemia. So, number is not very minimum. And in the recent study in the heart failure patients, the overall actually the incidence is 2.9 per 100% per year. So, it is quite a common issue of hyperkalemia in these heart failure patients. Now, today I am going to share one interesting, very beautiful article. Is basically the randomized RALS trial and analysis of this RALS trial, and they have a very good insight of this study and what are the outcome. I will go in my in my next few slides. So this is a potassium level. You can appreciate the patient who are actually on spironolactone. They have a higher potassium level, almost 0.25 milliequivalent than those patients not having this spironolactone medicine. Now, those who had attended the study during a drug dose of 25 milligram had a 13% risk of hyperkalemia. So this is very important. But if you increase the dose just to 25 to 50, if you double the dose, then the chances of hyperkalemia becomes 41%. So it is not just doubling; it is more than that. So 25 and 50 milligram has a significant effect on hyperkalemia in this trial. Now, this is another very interesting slide. Is a landmark analysis. It was observed a U-shaped relationship between the potassium level at 4 weeks after randomization and subsequent rates of mortality in the both treatment arm, such that this subsequent rates of death were highest in patient with the lowest, that is the those having the potassium less than 3.5 millimole, and the highest, that is the those having the potassium 6 millimole at when the potassium was measured at 4 weeks. Nevertheless, across the spectrum of the benefit of spironolactone relative to placebo was maintained, with a higher mortality rate in the placebo group than the spironolactone group at any given level of 4 weeks potassium level. So this is very interesting. This is a U-shaped curve. Now, this is another analysis with a hazard ratio with a 95% confidence interval, and this showed that the treatment benefit of spironolactone seems to be maintained. So I repeat, it seems to be maintained at least until potassium value exceeds 5.5 milliequivalent per liter, and dotted line represents the 95% confidence interval. So what are the points to be noted from this study? So it was found that in patients with the severe heart failure enrolled in RALS, potassium level rose within 4 weeks of the randomization of spironolactone and remained elevated for the duration of the trial. So this is very important. Now, patients randomized to spironolactone derived benefit at least until potassium level exceed 5.5. So this is a cutoff 5.5. This finding suggests that the spironolactone maintained its beneficial effect in most patients with the severe heart failure exhibiting modest elevation of potassium. And heart failure treatment guideline recommend initiation of the MRA only if the baseline serum potassium is less than 5 and EGFR is more than 30, and further advice on frequent monitoring of the serum potassium and the renal function. In RALS, although the potassium level remained higher in the spironolactone group, when compared with those in the placebo for the duration of the trial, the greatest change in the potassium occurs within the first 4 weeks. So this is very important. The first 4 weeks is very important after the initiation of spironolactone. This finding underscore the importance of early monitoring of the potassium after initiation of MRA because elevation occurs early. So this data suggests that hyperkalemia related to spironolactone may be dose dependent, and limiting the maximum dose to 25 milligram daily may reduce the risk. I have already explained that 50 milligram if you give, then your chances of hyperkalemia is more than 40%. So this is another paradoxical statement. So is hyperkalemia is beneficial? So if you go to the emphasis trial, in patient after myocardial infarction with the left ventricular dysfunction showed that early rise in the potassium level at 1 month with eplerenone was associated with the better cardiovascular outcome. So potassium, rise of the potassium is beneficial as far as the mechanism of action is concerned. And the emphasis heart failure study, a recent analysis showed that the survival benefit of eplerenone were maintained in the setting of hyperkalemia. So these two trials showed that the patient with the modest elevation of the potassium with the MRA will still derive benefit even in the setting of severe heart failure. And this finding argue against the practice of clinicians to discontinue the MRA after mild elevation of the potassium. So this is the one message. Now, this is another very interesting subgroup analysis of the paradigm heart failure trial. Actually, which they what is the topic? The reduced risk of hyperkalemia during treatment of the heart failure with MRA, use of sacubitril compared to NRP. So in the subgroup analysis, you can appreciate that the patient who are on ARNI and MRA and those patients who
वैसे
are
बैठ नहीं आ सकते।
on captopril, on enalapril and the MRA, the chances of hyperkalemia more with the enalapril group. So MRA with ARNI causes less hyperkalemia compared to MRA plus your enalapril. So this is one derivation. Now, this is a paradigm shift, and we can know that dangerous potassium elevation, that is more than 6 millimole, is less with the ARNI compared to your enalapril group. So once there is a hyperkalemia, so what are the options? So if it is emergent, that is if the calcium is more than 7 and there are ECG changes, so there is an emergency, and you should give the calcium gluconate, your insulin infusion, and beta agonist. In the intermediate CKD patient, yes, dialysis is the option. Loop diuretic, you can give Lasix infusion, it will cause potassium wasting, and sodium bicarbonate in the acidotic patients. And now maintenance, it is very interesting. Now review all the medications list and dietary supplements. So the diet is actually contributing to increase the intake of the potassium. So you should prescribe the low potassium diet, reduce the dose of the RAS inhibitors, and stop offending medications. And number 4, it is not it is basically underestimated the potassium binding resins. So these have also some roles in nowadays. Now this is the recommendation how to start ARB and how to your ARNI and how to monitor. So this is a clear cut recommendation that start with a low dose, and if maximal dose are not tolerated, then lower dose should be maintained. So this is number 1. Number 2, now guidelines suggest that increasing the dose at no less than every 2 weeks unless it is an inpatient setting, and blood testing should be done 7 to 14 days after every increment. So this is very important, and after any titration of the doses, and then every 4 months interval. So this is the recommendation of the potassium monitoring in case of ARNI or ARB therapy or AC inhibitor therapy. Now what is the recommendation of the MRS? So so ACC recommend the continuation of the MRA when the serum potassium level is less than 5.5. If the serum potassium is more than 5.5, current recommendation is to halve the dose and closely monitor the blood chemistry. If the serum potassium is more than 6, cessation of the MRA therapy is advised. And obviously, I have already told that your potassium hyperkalemia is more common in the first 4 weeks. So initial after 2 weeks, you should have definitely a potassium level at the 2 weeks and the 4 weeks. So this is very important. Now this is very interesting. Now, so what is the role of the now potassium binding resins in the current scenario? So this is the first potassium binding resin, the sodium polystyrene sulfonate. Actually, it is the K-bind sachet we are usually using. So this K-bind sachet, they are good for acute cases. Yes, acute hyperkalemia is giving K-bind sachet, but you cannot use in a regular basis because they cause colonic necrosis. So this is the main disadvantage of this sodium polystyrene sulfonate. Now come to patyromers and your sodium zirconium. So patyromers have definitely evidence, and they do not cause this colonic necrosis, but definitely they have side effects. And also the sodium zirconium, they also you can use, but robust data is not there. So what are the side effects of this patyromer and this sodium zirconium? So drug-drug interaction, edema, constipation, diarrhea. So GI upset is the more, and hypomagnesemia and hypokalemia. So what are the evidence gap? Still 2022, we don't have any significant your data, long-term use of these molecules. So this is important. Now, just 2 to 3 minutes, I am just finishing. So recently we have the patyromar for the management of the hyperkalemia in the heart failure. This is a diamond trial, and which clearly shows that patyromar can be, it was patyromar was used up to 40 weeks, even 48 weeks, and they actually reduce the hyperkalemia, those patients who was on RAS inhibitors, and there is a less discontinuation of the RAS inhibitor agents. So this is very important. Now just last 2 slides, we just finished with this Fineron group. So this is the non-steroidal your aldosterone MRA. So they have a very low your affinity for the sex hormone steroid and very high affinity to receptors. And this is the fidelity analysis, and they have showed a significant benefit in terms of the cardiovascular CV events and in terms of the kidney composite outcome. So, this is a good molecule. And why I am highlighting the issue of the hyperkalemia. So, there is a clear-cut evidence from this Fidelio's trial, the short-term increase in the serum potassium and the decrease in the EGFR with the funeral or placebo are associated with the subsequent hyperkalemia at 4 months. The magnitude of the increased hyperkalemia risk for any given chart change from the baseline was similar to placebo. So this is very important. So less hyperkalemia with this molecule. So it is my concluding slides. So RAS inhibitors and MRA are two main pillars in the heart failure management. Hyperkalemia often compel us to discontinue those molecules. Dose reduction can be helpful. Potassium binding resin, yes, these are very upcoming issues. Those patients who require these RAS inhibitors, but we cannot give due to hyperkalemia. We can continue with these newer potassium binding agents, only having less incidence of the fatal hyperkalemia. Newer generation of the non-steroidal MRA have shown lower incidence of hyperkalemia, and regular potassium monitoring is required. So thank you very much for the patient hearing. Thank you very much.
Okay, Priyam, it is an excellent talk.
Good. Yes, sir. Good evening, sir.
Hello.
Good evening, sir.
And I want to ask you one simple question, that in the diamond trial.
Sir, sorry
after
for the
you did
interruption,
better-
but can we discuss all the question answers later on after the completion of all the talks of the respected speakers? If we can do that, then
Okay,
we
okay.
can possibly move on to our next speaker, who would be Dr. Bashovendra Chaudhary.